is my great honor to welcome you all to Dr. Kakarla Subba Rao Endowment lecture on the X-ray vision that clinical medicine affords us, the art of contributing clinical science and radiological science. This lecture is a tribute to the legendary Dr. Kakarla Subba Rao, whose contribution in the field of medicine and radiology has left an enduring impact. We extend our deepest gratitude and welcome the family of Dr. Kakarla Subba Rao. We are privileged to have Professor Umapathi N, Thirugnanam, Senior Consultant in Neurology at the National Neuroscience Institute, Singapore, as our distinguished speaker. His expertise will provide valuable insights into the profound impact of clinical evaluation in localizing lesions. Professor Umapathi, we are truly honored to have you here and are eagerly waiting for your lecture. To everyone gathered here, thank you for being a part of this occasion. Let's engage, learn, and get inspired. Welcome and enjoy the session. I now call upon Dr. Tarjini Dave, Associate Director and Oculoplasty Consultant, to brief us about LV Prasad Eye Institute.
Good evening, ladies and gentlemen, dear guests, Dr. Kavita, Professor Umapathi, thank you for being with us today and joining us. I'm Tarjini Dave. I'll take you through a little bit about what LV Prasad Eye Institute has been. As most of you know, we are a not-for-profit organization working towards preventing needless blindness and vision impairment. The indomitable will of the founder chair, along with a generous donation from the Prasad family, has made LV Prasad Eye Institute what it is today. The evolution of the institute is interesting. We began at this very piece of land where you're all seated. This then thought of as a barren piece of land with boulders where the foundation stone was laid in 1986 on 17th of October. You can see pictures from the ceremony here. And we saw our first patient on June 1, 1987, that little boy you see in the picture cutting the cake with Dr. Rao. This has grown over decades from what was a small setup to what is now an institute and an institute of excellence. We had one building, what we now call the GPR building, the Gulapalli Pratibha Rao building, which grew into what is now the current Kalamanji Reddy campus, where we've added the Velamati Saubhagyavatama wing, to what is actually LV Prasad Eye Institute. And this, ladies and gentlemen, 310 centers that you see spread across 3 states, Telangana, Andhra Pradesh and Orissa, with a little presence in Karnataka at Bellary, is what LV Prasad Eye Institute today is. We have a pyramidal model of care that you're able to see on the side corner there, and I'll take you through a little bit of this pyramid via our functional arms. We operationalize ourselves through these 10 functional arms, and I'm going to introduce these to you briefly, albeit. Now, the signature of LV Prasad Eye Institute is our rural and community eye health. This is what sets us apart from any other eye organization in the world. And why do I say that? I say that because we serve people who do not have access to care. The very base of our pyramid is guarded by the vision guardian, who's a representative from the community, who's hired to take care of people in the village, and looks at smaller things like school screening, community screening, those who've had surgery at a higher center and have come back home, takes care of those patients, and refers patients to a vision center when they require glasses. This is manned by a vision technician and serves in advising people when they require more advanced eye care and providing basic necessities like spectacles, and taking care of whatever the vision guardian has referred the patient for. From here, when care demands a more intense approach, the patients are referred to a secondary center, and we have about 27 of these at this point of time in the 3 states that I mentioned, where we have an ophthalmologist and a team taking care of diagnosis of eye-related conditions and performing surgeries such as cataract surgery. They also monitor the activities of vision centers and help with the screening programs in the community. Here's where we integrate with a larger part of patient care, and the remaining 2 tiers that you see, the tertiary centers and the quaternary center, the center of excellence, is where we perform more advanced and subspecialty eye care for patients who have these requirements. We also see a lot of patients that are referred from within our network. The Center of Excellence additionally has the scientists, the public health specialists, and several people in administration that help, along with eye care, take care of a lot of other things such as technology, innovation, capacity building, product development, very hardcore research, and mobilization of resources for our entire tier. With this pyramidal model, we provide care which is excellent and equitable, and care which is appropriate, available, affordable, and accessible to people. We conduct from screening to management of the most complex eye problems, and we also take care of those who have blindness and vision impairment by providing rehabilitation. Within this pyramid, we have a top-down and a down-up sort of integration, and I'll give you some small examples of it. So you see these 2 images over here. This is a patient who's in a vision center, has an eye problem, and what has been done is to use technology to capture an image which is seen by a specialist at the top of the pyramid, and that specialist can now tell what is the problem with the patient and help with the care of the patient while the patient is sitting at the vision center closer to the house of the patient. And that's a top to down sort of integration of care that we have. Similarly, we have faculty trained in corneal transplants traveling to the secondary centers, performing the corneal transplants closer to the patient's home, and letting the patient remain in the care of a trained ophthalmologist who mans that center so that the patients don't have to travel all the way for advanced eye care. Not only faculty, we also have equipment, certain very high-end specialized equipment which also is made to travel to the various centers where this may not be available, and therefore any traveling faculty from a particular specialty has access to all these diagnostics that are otherwise available only at the tertiary center. A similar thing is where we are reaching out to patients closer to their homes by providing what we call home care. This is in the urban areas as well as some of the rural areas. We have an electronic vehicle with diagnostic equipment that goes to the patient's houses and performs screening for those particular individuals that may find it difficult to leave their house and come to an eye care facility for basic examination. Here's a small snapshot of what we've done in 2024, about 2.5 million patient services that we've offered. And if you look at it, about 50% of these services have been free of cost, amounting to about 970 million non-paying services that have been offered. Close to about 38,000 individuals have been provided vision rehabilitation in this year. Slowly taking you through the other components, iBank again is a core integral component of LV Prasad Eye Institute, and this graph shows you how from the inception slowly the number of corneas that have been harvested as well as utilized has constantly increased and has shown an upward trend, except for a small dip during COVID. We work out of our eye banks, which are present at all our tertiary centers, and we've also helped develop capacity in forming or establishing eye banks in certain other parts of the country. For instance, we have one at Banaras Hindu University, which has been established with the help of Hans Foundation. And we recently celebrated a unique milestone of performing 50,000 corneal transplants probably the single largest number by any eye care organization in the world. With the iBank setup, we move towards an audacious goal of providing not only corneal tissue but also cells and other tissues, and develop a more wholesome bank that delivers all these end products for people with various eye diseases. The other signature to LV Prasad Eye Institute is the Vision Rehab, and we've had rehabilitation performed for over 275,000 individuals since inception, with a lot of these people being able to gain back their livelihood and live a very respectable life. We also make sure that they get appointed to several jobs that are available in and around the areas where they live, and this probably is something that again sets us apart from other eye institutes in the world. We provide training for all cadres of eye care personnel that will help in the delivery of eye care services, not only ophthalmologists and optometrists, but also those who would help with nursing, certain other technical training domains, as well as those who would like to go ahead with management in eye health. And all of these are trained within the Academy for Education of Eye Care Personnel. We've trained almost 5,500 trainees over this period of time, and about 50% of these are ophthalmologists. This is just in the 1 year of 2024. Training has also extended to another center in Western Africa, which is Liberia, where we've helped set up an eye institute. And also, this is the first ophthalmology setup in the country for whom we've not only trained the ophthalmologists but also the other allied eye care personnel that will help run that center. Research has been an integral part of LV Prasad Eye Institute, and we've ranked 7th in the Simago Institute's ranking. This is a global ranking, and you can see that from India, it's just LV Prasad Eye Institute that features there. We've had about 367 publications in April to March 2024. But if I have to give you the ethos of research at LV Prasad Eye Institute, then that would be something like this, where we bring the entire loop of research from the idea to the final translational aspect in patient to life, with the help of different components that we have in research. We have labs, we have a 3D bioprinting facility that we can avail from here, to animal model trials, to fabrication in the GMP facility, finally a pharmacy that can compound things, and then to clinical trials to prove that whatever you had set out to research actually works. This entire pipeline is what makes research at LV Prasad Eye Institute unique. And what's also nice is that there is digitization of this entire effort, from the application of the grants to the final reports that are generated. Through the technology and innovation arm, one of our biggest products has been our homegrown electronic medical record, which has had about 15.1 million patient visits. It has almost 7 million unique patients, and about 12,000 patients are registered on this on a daily basis. This is used not only within our network but at several other countries that have purchased the electronic medical record from us. We also have a healthcare technology incubator, where ideas in technology are taken forward and innovations are brought out that will help eye care in a much larger fashion. There have been several products that have come out of this innovation effort. These are the in-house products that have come out, from devices as simple as a grabby, which just helps patients get a standardized photograph that their healthcare provider can see, to something very complex that measures the visual field in a child, a pediatric perimeter. All of these have been grown in-house over the past couple of decades. And finally, we've worked in policy planning and in advocacy. We've been there. We've initiated the Vision 2020 program and the AP Right to Sight in our part of the world. We've hosted several WHO meetings as well as the IAPB meetings, and a lot of our faculty are members on these. We've played a pivotal role in the national government bodies within the 3 states where we are present. If I had to sum all of this up, then this is the impact of all the functional arms. We've received the Goldberg Prize for having the greatest impact towards advancing vision restoration in human patients. We've received 3 Padma Shris, 4 Shanti Swarup Bhatnagar awards from the Government of India, 1 J.C. Bose Fellowship. All of this simply because of the value system that we have. All of us work around these value systems of patient first, excellence, togetherness, integrity, and equity in every single thing that we do. We've had tremendous support from people around the globe, a lot of which has allowed us to do what we do. One of that is also the support that you have provided in terms of the Kakarla Subba Rao Endowment Lecture. Thank you very much for that. We also have a committed, extraordinary team that works with us, that is led by a very, very able leadership, which is launching us into our next sphere. And this is just a snapshot of our performance since inception, where we've seen 24 million, we've provided 24 million center-based and about 14 million community-based services. We've performed about 2.5 million surgeries, seen about 5.5 children, reached about 13,000 villages, had about 5,000 publications, trained about 71,000 individuals, and we've also reduced 6,100 tons of carbon usage. And how do we do that? We do that with the help of 3,000 odd trees that we have planted in our network that take care of the carbon dioxide emission. If I had to finally sum this presentation up, what is LVPEI? LVPEI is an eye care organization that provides appropriate, available, affordable, and accessible care via the physicians that not only use their heads and hands but also their heart, and a team that is very talented, uses technology appropriately with tenderness to become an organization that is relevant and caring. Thank you very much.
Good evening, everyone. At the outset, I would like to thank the family for having this endowment lecture. This is our 3rd lecture. Thank you very much for having, because this endowment lecture, every time it happens, it leads to 2 things in every one of us. One is celebrate the life of here, Dr. Kakarla Subba Rao, what he led. And the second thing is, we always eager to hear some eminent clinician or scientist from within the country or around the world. So these are the 2 opportunities we look forward every time. I just wanted to tell a brief about it. It's not 3-4 minutes are not enough. As you know, you can see the awards and the degrees there of Dr. Kakarla Subba Rao. He's an American board examination he completed, and he became a special fellow, both from he has a fellowship award from US as well as from UK. And after this he came back to India. You know, we are very proud of people who come back. Dr. Rao is one of them. So you know how impactful they can be. So he came back, he joined Osmania Medical College, and then he went back to US, and he was a faculty of radiology at several medical institutions during this period. He had a fantastic academic life there, and he was publishing prolifically, and he won so many awards over a period of time. And then he decided to come back. You know, there are some people who build our nation we say when we have these great medical institutions, it's one of the stepping stone to build the nation. So Dr. Subba Rao is one of them who helped us to rebuild, most of you know, the Nizam's Institute of Medical Science into a very premier healthcare center, specifically on the neurology side. So he came back, and then he was as usual, he was an outstanding radiologist of international repute, and he was honored by the government of India with the Padma Shri as well. But L.V. Prasad has a unique story with Dr. Subba Rao. Every year we remember this. Dr. Rao had a conversation with Dr. Subba Rao way back. He asked, can we start a HCRP program? Full form for HCRP is a corneal hospital-based corneal retrieval program. Why it is important? At that time, the donation of eyes were not very common. So our grief counselors, can they be placed in NIMS hospital? Dr. Rao always says, within a minute, he said, it's absolutely fine with us. As we celebrate this eye donation and 50,000 corneal transplantation, Dr. Rao says, this is one of the initial decisions which helped us to reach this. The whole eye banking system within India, that's one of the small decisions, but he took probably less than 30 seconds to decide on that. So that's the way he used to work. So we are very, very thankful. From radiology to neurology to the eye, we have a very significant connection with Dr. Subba Rao. I always remember this quote from him, philosophy of life. I pass through this life only once. Let me do the maximum good to the largest number of people. I think that's the biggest inspiration for all of us. And I'm very happy to welcome you all for this third endowment lecture. The first one was a neurologist, Dr. Lekha Pandit. Last year we had a neurosurgeon, Dr. Manas Panigrahi, and this year we have a neurologist. I will say he's more of a neuro-ophthalmologist. I would like to invite Virender to introduce our guest. Thank you very much.
Good evening, everyone, once again. It is indeed a pleasure and privilege for me to introduce our guest speaker, Dr. Umapathi Thirugnanam. He is a senior consultant in the Department of Neurology at the National Neuroscience Institute in Singapore, as well as in the Department of Neuro-Ophthalmology at SNEC. He also holds associate professorship at the Lee Kong Chian School of Medicine at the Duke NUS Medical School in Singapore. So he has a lot of special interest in neuromuscular disorders, eye movement disorders, autonomic nervous system, neuroimmunology, especially Guillain-Barré syndrome, where he is one of the authorities, diabetic neuropathy, and infectious diseases affecting the central nervous system. I would also like to place over here that he did his fellowship with Dr. David C. at Baltimore in the field of eye movement disorders, and he is one of the persons who can simplify understanding of supranuclear eye movement disorders and nystagmus so well that anybody can understand. He is also an active executive member of the International Peripheral Nerve Society, Asia Oceania Myology Congress, and he's the co-chair on the Educational and Training Committee of AOCN World Congress of Neurology. So, apart from the academic accolades, I would like to tell something more about him. He is a visiting consultant to many places, especially in the underprivileged societies. He visits Myanmar, Vietnam, Sri Lanka. In the far west of India, an NGO called Search, he goes to a village called Gachiroli and he serves the underprivileged people over there. He is very happy to share the treasure of knowledge that he has, his time and talent in training the neurologists and neuro-ophthalmologists. He is an excellent orator. You will see through his presentation, he will bring in humor and oversimplify the things so much that all of us can understand it rather than trying to memorize few things. As I said before, he is eager to share knowledge and serve the underprivileged. So that's Dr. Umapathi Thirugnanam for all of us, and I welcome you once again for delivering the
So thank you, Virendra. As a neurologist, my first instinct is to test whether, I know Virendra doesn't drink, but to test whether he's confabulating from Wernicke's encephalopathy, because half of the thing he was saying was confabulation. So. But I know he doesn't drink at all. So thank you, the family of Dr. Rao. I've heard a lot about him, and it's a great privilege to be here. I just want to share with you my experience with radiology and how it helps the clinicians. But I also want to share with you some of my thoughts about some of the powers that clinical medicine gives that possibly equals the powers of radiologists. So at the end of the lecture, you all have to feel, especially the hardworking juniors in the audience who have to do very long hours in the hospital, that they feel like they are superheroes doing superheroes work and helping people in the world. How will I convince you? Well, you have to wait till the end of the lecture. So I'm going to start off with a story of a real story, no fake news. So this is a patient that I had to see with my resident in the emergency department. So as you can see, he came in for vertigo, and the emergency doctor had noticed that he possibly had mild left ptosis. The resident was with me, looked at me and said, when I said, yeah, he indeed has evidence of left ptosis. Now, this resident was actually a very good resident because he, unlike agreeing with me all the time, if he feels differently, he openly expresses. And that's something I like to inculcate in my residents, because that way I know that I'll be checked. So I had to convince him that this patient had ptosis. So what did I do? So I told the patient to look up until the right eye, the limbus clears the lower eyelid. At that point, if you look at the left eye, you notice that the left eyelid is actually going up and covering the southern pole of the iris. So this is what we call the reverse ptosis or inverse ptosis sign. Now once you see that, you know for sure that this is real ptosis, but not just real ptosis, but a specific form of ptosis that you see in Horner syndrome. So the next thing then to do is to look at this is a simple diagram that I often give my residents whenever you see ptosis. The key feature to differentiate the different types of ptosis is to look for the pupillary abnormality, because that will differentiate one cause from another. And this morning we were discussing, one of the residents was asking me, why do I have a zebra there? Now, this is one of my favorite clinical reasoning principle. Now whenever we have different things that look the same, it's no point we talk about the same thing. We have to talk about something that's special and distinctive. So if you are looking at animals in Africa, many of them have 4 legs, many of them eat grass, many of them are found in the Serengeti, lions like to eat them. But if you want to know what a zebra looks like, you must tell them specifically look for an animal with black and white stripes. So in this case, if you want to differentiate the various types of ptosis, the key thing is to cut to the chase and go straight to look for the pupils. Okay, in this case, the pupil was clearly myotic. So with this, the diagnosis is Horner syndrome, right? Now, in many parts of the world, people are taught that once you get Horner syndrome, the next thing is to confirm it pharmacologically or do imaging. But then if you think about it, like what we were discussing this morning, the sympathetic fibers have a very straightforward sort of simplistic path to their final location. They start in the hypothalamus, they travel down the brainstem, become eloquent or prone to disease in the lateral medulla, travel down the cervical cord, and they become very silent in the cervical cord, and then they suddenly appear in the thoracic cord. And being a silly nerve, it suddenly realizes that it should have gone straight from the hypothalamus to the eye. But it suddenly appeared at the thoracic cavity and realizes, oh no, I have to get back to the eye. So it looks around and finds the carotid artery. And so what does it do? It tries to jump onto the carotid artery. But the carotid artery is too far. So what does it do? It does a somersault on the apex of the lung. So if you remember this story, you'll know that there are only 4 locations where sympathetic fibers can be abnormal, lateral part of the brainstem, lateral medullary syndrome, so called Wallenberg syndrome, the T1 thoracic spine, apex of the lung, and finally carotid artery. So only 4 areas. So with that, my resident and I started examining the patient further, and we found nystagmus. Now again, among the 4 entities, nystagmus is only seen in the brainstem. So straight away, the plot thickens and we know that it's likely to be lateral medullary syndrome. Then we go on to do the rest of the cranial nerve exam, and here I'm showing you the abnormal corneal response on the left side. And in the next video, I'm showing you that this patient's coordination is abnormal on the left side. So, abnormal Horner syndrome, cerebellar signs, worse on the left side, ipsilateral fifth nerve palsy, and surprisingly, if you can hear his voice, he will be telling you, doctor, everything seems to be on the left side, but when you put a cold metal object on my right side of the body, I can't feel the coldness very well. So something is wrong with the temperature sensation on the right side. So that means spinothalamic fibers from the right side of the body are not being detected in the brain. So with that, my resident and I took out a picture of the medulla, and we drew circles around all those structures that we thought were abnormal in this patient. And then we drew this picture onto that was still the days when we could write paper forms. There was no electronic records yet. So we drew this picture, stuck it on there, and sent it to the radiologist. The radiologist was a very kind person, so she immediately called me back and said, yes, indeed, the MRI fits exactly where the lesion should be. So this is an example that I always tell my residents that, if you are already suspecting based on clinical signs, okay, you can actually tell the radiologist what to tell you rather than the radiologist tell you what to do. And that makes a lot of sense, because you would see a lot of times referrals coming to you, or the x-ray shows this, what does it mean? And I always turn around and tell my residents that now you're giving me 2 problems. One is the patient's problem, which I need to solve, and another is a man-made problem, which is what the x-ray is showing. So I rather have one problem. So I always feel that you use clinical science to dissect the patient's body. Clinical science is a magical field that allows you to look into patient's body, right? You're able to look into the patient's eye, you're able to look into the patient's body, and the geneticists will tell you that you're even able to look into the molecular level and predict what gene it is, just based on you see a trisomy finger, or you say, oh, this must be chromosome 21. Now, if you were to be in a primitive society, the primitive, the chieftain will be saying, oh, this must be a witch doctor. How did he know that this person, by just looking at the hands? It sounds like magic. And that's what Albert Einstein said, right? Magic is what it is until science proves it otherwise, right? So clinical science is actually magic that's given to us. So we shouldn't give it away. We should embrace it and use it, just like the magic of radiology gives us with regards to looking into the patient's body. Okay? Now, further points. This morning we saw this man who had what looked like an internuclear ophthalmoplegia, right? And we dissected out his eye movement abnormalities by using a series of diagrams. So we said that when he's looking to the left, this is the diagram that will represent his eye movements. The 6th nerve is connected to the lateral rectus muscle. The 3rd nerve is connected to the medial rectus muscle. And the connection between the two is the medial longitudinal fasciculus. And this will tell you that there are 4 possible causes for this patient's problem. But with a series of clinical examination, we confirmed that this patient had internuclear ophthalmoplegia. Not by default, but by design, right? This morning we did it. And we said that the lesion should be in the medial longitudinal fasciculus. And we told the radiologist where we should find the lesion. Okay, which is basically, this is a section that's very important for ophthalmologists, because if you look at the section of the pons that looks a bit like a heart shape, now in the inferior part of the heart, you see what looks like 2 very prominent, like the udders of a cow, right? Now these 2 prominence is because of the 7th nerve being a very prominent motor neuron. So therefore, when it's circling around, it's occupying a lot of space. So that marks the facial colliculus, right? So in between the facial colliculus is the medial longitudinal fasciculus. So many times people report of internuclear ophthalmoplegia with normal MRI, and that's because we are not looking exactly where the lesion should be. As you can see, among all the gray matter and the white matter that you are seeing in radiology, only one small section shows one small dot. One small section shows one small dot. So your chance of missing it is very high unless you have a priori hypothesis. So we tell the radiologist, please tell us that we are right, that there is a lesion on the right side of the brain and it should be in the right pontine medial longitudinal fasciculus. So this we discussed this morning, and many of you will be wondering, is this a rerun of Rajinikanth movie? Why are we rerunning the show again and again? So it shouldn't be, right? So I should give you something new. So what is new? We were saying this morning, why is this patient having an upbeat nystagmus? Why is a patient with internuclear ophthalmoplegia having an upbeat nystagmus? So for that, I need to take a step back and explain to you, why do you get vertical nystagmus in the first place? Okay, for that, I need you to participate with me. Okay, you're going to answer the next question. The next question is, okay, now, what are you guys doing? I see a lot of you are shaking your head up and down vigorously. Now, when you're shaking your head vigorously, you're still, some of you are looking very stern. So I suppose you are the Americans who must have voted for him. But the rest of you who are shaking the head vigorously are able to read the question and still shake the head because of something called the vestibulo-ocular reflex. Now, I'm going to make you go back to your medical school. Vestibulo-ocular reflex, you have 3 semicircular canals. Okay, I will dissect out my mastoid bone to show you, and I will enlarge it for your benefit. This is the superior canal, this is the posterior canal, and this is the lateral canal. And then there are another 3 canals here. Okay, 3 canals, just like your water bottle, is full of fluid. So when the water bottle moves, the fluid moves. So these semicircular canals are going to move, and these signals are then transmitted to the relevant oculomotor nerve, so that we can continue to foveate without volitional thinking. So we can foveate at the target. So now I'm looking at Dr. Prashant. I don't have to think about look at him, right? I can turn my head, but I'm still foveating on you. I can turn my head this way and I'm still foveating on you. That's because my posterior canal and superior canal are working. If I were to do this, which we do a lot in our countries, okay, these 2 semicircular canals pick up the signal and our eyes are able to rotate that way, correct? So that's how we have the vestibular-ocular reflex. But there's a problem. The vestibular-ocular reflex starts in the vestibular nerve, and that's in the medulla. Now, what's responsible for vertical movements? 3rd and 4th nerve. Where are they? They are in the midbrain. So things have to get from the medulla to the midbrain. So how can you get that? The main elevator we talked about just now is the medial longitudinal fasciculus. So in other words, the medial longitudinal fasciculus is just like our highways. Anybody can just get into it and go from one place to another. So the signals from the vestibular canals that are responsible for their vertical VOR traverse up the medial longitudinal fasciculus to the 3rd and 4th nucleus, so that when you do this, you are able to bring your eyes down. When you do this, you bring up. Okay, so that is the vestibular-ocular reflex. Now, there is also a horizontal vestibular-ocular reflex, right? Now, horizontal vestibular-ocular reflex is not a problem, because when you move to the left or move to the right, there's no bias. I know in some countries like India, the right wing is getting stronger, but left and right is normally not very different, right? But up and down is very different in any part of the world. Why? Because of this thing called gravity. Now, this is going to be difficult for the brain to deal with, because this is not the volitional brain, this is a reflex brain. It has to deal with movement down. When I move my head up, my eyes have to go up. It has to overcome gravity. When it's doing this, it's coming down. And when it's coming down, it didn't ask for help, but gravity is going to help. Now, that's going to be a problem. When eyes go down, gravity is helping me. I didn't ask for help. When it's going up, gravity is impeding me, and that's going to be a problem. So to counter that, we actually have another pathway. Okay, many of you may not have read about it because it doesn't really get into the textbook. But a lot of it's written by this group of authors. Okay, this paper which I'll reference later. Okay, this pathway It's been proven quite well in animals. But in humans, it's a problem because it's not been very clearly demonstrated in enough post-mortem cases. But I'll tell you why this is relevant for today. This pathway is important because it's called the central ventral tegmental tract. It starts from the vestibular nucleus, traverses up and goes to the third and fourth nucleus and fires continuously to counter gravity. And it's a tonic activity. But the problem with tonic activity is that, like our ancestors in the past, monkeys and some of us who do yoga, we are not always this way. Sometimes we go upside down. When we go upside down, the gravity and CVTT will be in the same direction. So that will be a problem. So CVTT cannot be uncontrolled. So who will come to control? Of course, Saraswati. I think the students know who Saraswati is. The rest of you have to come to my lecture tomorrow to know who Saraswati is. Well, actually, Saraswati is our cerebellum. Okay, you know why? Because if you look at Saraswati, she's got multiple arms. She's doing multitasking, but looking very serene. So that's what the cerebellum does. And it's a she because, it does all the things, but doesn't take any credit. Like the frontal lobe is a man. Frontal lobe is a man. It does all the bad things, like drinking alcohol, gambling and all these things. Cerebellum does all the important work, but doesn't take any credit. Okay, but anyway, so cerebellum is responsible for controlling CVTT also. Okay, how does it control CVTT? By inhibiting. So this is very important for this morning. We saw the patient. Yeah, so this part I didn't explain. I left it as a mystery for today. So basically the flocculus, part of the cerebellum, has inhibitory effect on, so it's like the horse. The horse wants to run away, CVTT. It's pulling back, flocculus is pulling it back. Okay, so when you have a lesion in the flocculus, like we discussed this morning, what will happen? Let's imagine CVTT is not work. CVTT is uncontrolled. It's overacting. So what's going to happen? Eyes are going to drift up, and because I'm conscious, I'm not going to be happy with that. I'm going to have a reflex. Boom, drift up, boom, drift up, boom, drift up, boom. That's downbeat design. So it's as simple as that. Highly localizing and very elegantly explained. A lesion in the flocculus, and we discussed this morning. This will what the patient will look like. Pop, 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 pop. All nystagmus has got sound, right? We'll talk about that tomorrow again. So, and the causes are there, and all these causes are specific for the flocculus. Okay, but why am I talking about this in a radiology plus clinical science meeting? Because we were discussing this patient, remember? That patient with upbeat nystagmus. So we need to explain our upbeat nystagmus in our patient. So now we have to go to the counterpoint of downbeat nystagmus, which is upbeat nystagmus. So this is what upbeat nystagmus looks like. So you have to give her credit that even though she has upbeat nystagmus, she took time to put mascara. And now you know what, and you can understand why the mascara is so smeared up, right? Because, right? So anyway, so that's upbeat nystagmus. So upbeat nystagmus is also very easily explained. Now CVTT, when it's inhibited, okay, everything is controlled. When it's loss of inhibition, CVTT is overactive, right? But there's a lesion in CVTT now. What is overactive? Gravity is overactive. So what happens when gravity is overactive? Ice balls will drift down. The correction is pop, down, pop, down, pop, down, pop, down, pop. That's upbeat nystagmus. So any lesion in the CVTT will cause upbeat nystagmus. But unlike the flocculus lesion in the cerebellum, CVTT has got a long path. You see that? It starts in the lateral medulla, goes up, turns at the mid pons, goes up the pons to the midbrain to the third and fourth nucleus. So anywhere along the side, a lesion can cause CVTT. So upbeat nystagmus, unlike downbeat nystagmus, tells you it's brainstem, not cerebellum. Brainstem, and the localization is dependent on the coexisting signs. Coexisting signs. So all of you will be able to tell me this patient's upbeat nystagmus, and you can see the upbeat nystagmus of his eyelid also, is due to you see his left eye, he's got a complete third of the left eye. So he's got a cavernoma in the midbrain, causing a complete third nerve, and because the CVTT is entering the third nerve, it's being damaged, so he's got upbeat nystagmus also. If you lift up the other eyelid, you will also see a bit of upbeat nystagmus. So guilt by association, this is upbeat nystagmus in the midbrain. But coming back to our patient, Poor man is still waiting for us to answer his question. We have to give him a break. After this, he can go and rest. Why is his eye having upbeat nystagmus? When all I saw in his scans was a lesion in the MLF. I showed you the scan. So where is his lesion that explains this? So we sat down and thought about it. There's only one lesion on the scan. This is in the MLF. How can this lesion alone cause upbeat nystagmus? So we went back to the original paper and we took the picture, because this is not post-mortem studies, right? This is radiological post-mortems, right? There's a whole area of neurology that was eliminated by the work of radiologists like your father. Because of lesions that they found, we discovered anatomical areas that we didn't understand exist in humans. Because we cannot do as much we can't do that much work on the brain, right? There's only so much, especially nowadays. It's not easy to do postmortems. So a lot of it is what we call lesionology. You see a lesion on the radiology, you look at the deficit in the patient, then you say, oh, that must be the area that's functioning for this. So this group of authors in France came up with the localization of CVT by doing a series of patients with upbeat nystagmus and localized it in the pons to be there. So that is where the lesion is, in the pons. Okay, so that's what they have told us. But in our patient, we only see a lesion here at the MLF. So where is the lesion? So remember I said we would like to tell the radiologist what to find. They didn't find it. So we call the radiologist and say, can you repeat the sequence, but not the whole brain? Just cut closer to the original location of the pons and see if you can find a lesion that fits this. Again, we cut out the picture and send it to her. So this is the picture we sent to her. Okay? And lo and behold, she immediately called us and said that the fine section shows a lesion exactly where the next cut actually shows there's a lesion up there. So these kind of studies prove the original authors that the CVTT does exist, because it's been shown in animals but not shown in. So again, clinical science gives you the radiological, together with radiologists, helps you look into the patient and understand not just pathology but physiology. We can understand that the CVTT really does exist. You may say this is a single case. So then we started looking for more and we found this patient who had a left INO this time. Left-sided INO with upbeating nystagmus. She was easier because in the original scan itself, you could see that a lesion starts at the MLF and extends up to the CVT. So again, we believe now that INO lesion by itself shouldn't cause very prominent upbeat nystagmus. You have to look for additional pathology in CVT. So this is one example of how radiology and clinical science can work together to make things better. How am I doing for time?
5 minutes.
5 minutes, okay. In 5 minutes, I should go to something a little bit more esoteric. Okay, this is a man who came to us with a left upper quadrant enopia. Now, the students know left upper quadrant enopia. I try to keep it very simple. The localization is either the occipital lobe or the temporal lobe of the opposite side, right? Now, contrary to what is described in the traditional textbooks, there is no way for you to differentiate between the two just by looking at the quadrant enopia. You have to look for the company that it keeps. Occipital lobe is isolated with no other signs because occipital lobe is the fidelity is very high. She doesn't do anything else, only vision. Doesn't meddle with anybody else. Okay, but the temporal lobe, parietal lobe, they do other things. Okay, so what other things? Like this man, he says that stick is, you see what he's trying to do? I'm trying to ask him to cut the stick into half. Now, for person with homonymous hemianopia or quadranopia, the half will be in the center, right? Because he's able to readjust his eyes. But he cuts it towards the side of 1/4 of half. So what's that? What's that? Visual neglect. Because as you know, the temporoparietal lobe is responsible for your brain's ability to appreciate space. So not only does he have a quadranopia, he also has neglect. So that straight away tells you this cannot be a occipital lobe lesion. This must be a temporal lobe lesion. So we were happy enough to say we have found the lesion. We will tell the radiologist, please find us a lesion in the temporal lobe. But then my therapist came and said, doctor, there's a trouble with this patient. He's a worker in a construction site, and we need to make sure that he can get back to work. But I cannot understand his deficits. Is he faking it? Because he seems to be more disabled than he should be for a person with just quadranopia. Just one quadrant is gone, right, with a bit of neglect. So why is he so disabled? So I decided to sit down with him. And for those of you who understand Tamil, he speaks Tamil, so it's easy for you to understand. The rest of you, I'll give you a bit of translation. Hopefully his volume comes through. First, I showed him this picture. This picture, as you know, is a very anglicized picture. It's only relevant for Western countries, right? But they are not happy with it because you know why, right? Because the woman is washing the dishes. So they have changed it now to this picture. But unfortunately, I couldn't get it in time. But we have an Indian picture, You know what's an Indian picture? There was this madam is slaving over the stove, trying to cook saag. And the Punjabi man is sitting there drinking whiskey. And the children are going to fall into the well. That's the Indian picture that we. So next lecture I will show you that picture. It has to be a Punjabi man because the saag takes 2 days to cook, right? Yeah, the proper saag. Okay. So I showed him this picture anyway, and he's describing in Tamil what he sees. Volume, sir.
You have to enable it in Zoom.
So basically he's saying there's lines there. What do you want me to say what these lines are? You can't say it's a curtain. Then he says he sees this lines coming down here. He doesn't describe it as water. He describes this as a building. He describes that as a building and doesn't describe it as a cabinet. Okay, and of course doesn't look at the left side of the picture at all. Okay, so what does that mean? He sees the images, no problem seeing the images, but he cannot. I better turn it off, right? He can see the images, but he cannot describe them what they are. So what is this? Now, notia in Latin means knowledge, right? When you don't have a knowledge, we call it agnosia, right? So what kind of agnosia is this? Visual agnosia, right? Okay, and to prove this, I showed him this, and again, if the volume is working, he will tell you he's seeing lines, but he cannot describe the umbrella. He cannot describe the cup, he cannot describe the saw, even though he's a construction worker, and he cannot describe the pear. So he just describes them as lines. So he's able to see, actually, if you think about it, as a child, for you to appreciate this as a pear, as a saw, it requires you to remember that the space within the diagram is important, outside is not important. And that is not something that a child knows when it's born. The brain learns. The brain learns that this is how I construct images. Okay? So that is lost in him. So what is visual agnosia? This is a beautiful diagram that illustrates very well that whatever that's coming to the occipital lobe has to go somewhere else for it to be processed. To be processed as what information? What is it? This is a stethoscope, this is a mic, this is a laptop. Okay, because you've learned it and you have kept it in your temporal lobe as semantic knowledge. So the information from the eye must get to the temporal lobe before it becomes activated and says, this is an apple, this is a table, this is a cabinet, this is a plate, this is water pouring down, right? Otherwise, they are just looking like lines. Now, the dorsal pathway is on the other hand, the wear pathway. The wear pathway that tells you whether the car is moving towards you or away from you. Okay, so this patient has got a temporal lobe lesion. We know from his neglect, but we also know that because of his visual agnosia, it must be definitely in the temporal lobe, specifically affecting the ventral stream. So we ask the radiologist, and that's the lesions in the left temporal lobe. Explaining his visual agnosia. Okay, and just to prove how brilliant this whole thing will look like, I'll show you another patient with the same lesion in another patient. I'm giving her, she's got beautiful cognition, beautiful language functions, everything. I'm giving her a spoon here, and in Mandarin, she's saying that this is something that I use with my hand, and I do this, but I cannot name what it is. She says, I don't know what it is. Then after that, this is, as you can see, old days when we're using the Nokia phone. And she says these two things are the same. Even the brand name is the same. I know it's the same, but I don't know what it is. She says that. But the most brilliant part is, when I gave her an apple, she takes the apple and says, I'm not sure what it is. And then she puts it on her nose and shouts, apple! Because she smelled it. So you can imagine the information for smell doesn't have to go through the ventral stream, goes straight to the temporal lobe from the olfactory lobe, and she could recognize it. So again, this is how beautiful clinical science can be in trying to dissect out the intricacies of physiology, especially for the nervous system. So I hope I have convinced you that clinical science is actually a superpower, because it allows you to see into a patient's body, into a patient's organ, into a patient's cell, into a patient's genome, right? And understand what's wrong with that person. Secondly, unlike our politicians, he is using the power for, Superman uses his X-ray vision for good. And doctors, the young doctors, those of you feeling very tired and disillusioned, as 3 a.m. in the morning when the patient is calling you for headaches, you feel very disillusioned with the job that you've started. But you must remember, it's the best job in the world, besides teaching, of course. Because it helps you, gives you a superpower, trains you as a superhero, and you go around helping people. Okay? So I hope this will encourage you to remember the fortune that we have in the career that we have chosen. Thank you.
Thank you, Professor Thirugnanam, for a very engaging lecture. So, as I said before, he will make the presentation very humorous and oversimplify it so that all of us can take something. And the biggest message I think that we all need to keep in mind is that clinical science are very important. Though a lot of imaging is ordered, but we need to look at the associations, we need to localize before we order the imaging, which is relevant to the care of the patients. So thank you very much once again, sir. I think in the interest of time we may not be able to take questions, but at this point of time I would like to request Dr. Subba Rao's family, please come on the dais to felicitate our guest speaker, Dr. Prashant Gar, our Executive Chair, Dr. G.N. Rao, our Founder Chair, Dr. Ramesh. With this, we conclude this edition of Dr. Kakarla Subba Rao Endowment Lecture. I would like to thank our guest speaker, Professor Thirugnanam, once again for coming all the way and sharing his knowledge. Family of Dr. Kakarla Subba Rao for all the continued support and joining us in person. I would like to thank Mr. Mahavi and Mr. Jacob for making all the arrangements. I would like to thank our administrators, communications team, IST team, and all of you for being there and providing all the support for making this lecture possible. Thank you very much once again, and have a great day.